Hello everyone.
Hello, Nada.
Hello everyone. Welcome to our free session today. I hope it will be a wonderful scientific night. I will leave you with Dr. Shaheen, our operation manager, to explain how we will proceed with the night.
Thank you, Nada. Hi, everyone. I really hope you will have a great night with us tonight. As we explained on our advertisement, we will hold this live VIVA session, a full simulation of the VIVA part of 2B exam in FRCR. Because we'll be choosing the candidate who will sit the exam through live draw. I kindly would ask all of you, those who want to participate in the hot seat, to please write your name in the comments section so we can choose one from those who are interested. While you are doing so, I'll take these few minutes to introduce our examiners for the night. Tonight we have Dr. Mohammed Amin, FRCR certified, 13 years of experience in radiology and 5 years of teaching experience. Someone who have mastered FRCR in and out with lots of tips and tricks. Hopefully you will learn a lot from him tonight. We also have Dr. Mahmoud Saidi, FRCR certified and a neuroradiology fellow in US. He also had done an emergency radiology fellowship in the US as well. With more than 11 years of radiology experience and 5 years of teaching experience, he shall have a lot to tell you about how to pass this exam. We also have Dr. Mahmoud Rizq. He is FRCR certified. He has a master's degree, PhD in radiology, along with European diploma in radiology. As you can see, we have a variety of examiners who shall give us a good experience, shall I say, a good taste of the FRCR exam. I can see that some of you has put their names in the comments section. I'll give another 2 minutes for you to finish writing your names in the comments section, and then we'll do the live draw. This night will go in 2 parts. The first part, after we choose one candidate, they will have 2 examiners. The 2 examiners will go through 6 cases of VIVA with them in 30 minutes. After the 30 minutes is up, they will give feedback about the answers in about 15 minutes. After that, we will take 5 minutes of break for those of you who want to do Maghrib prayers. After that, we'll come back for the second part where we will do another live draw, and the second candidate will have 2 examiners as well. They will go through another 6 cases with them. And then we will finish with another 15 minutes of feedback. Someone is asking, sir, do we have to write our names for the hot seat? Yes, please. If you can write your name in the comments section so that we can put your name in the live draw. We chose to do the draw live because we wanted it to be someone who is already attending the session. Okay, so I can see that 5 of you have already written down their names. Let me just share my screen while we do this draw. So as you can see, Laith was chosen as the one candidate to attend the hot seat. I wish you best of luck, and now we will go to one of the examiners to start the exam. Thank you.
Hello, everyone. Assalamu alaikum. I hope you are doing well, all of you. Okay. Dr. Saidi, are you here?
Yes, sure.
Do you want to start with Laith?
As you like.
He is the chosen one.
Okay, let's start. Hello, everybody. Assalamu alaikum. Nice to be with you again in this free session for the VIVA simulation exam. Where is Dr. Laith?
Yes,
Our
Dr.
good-
Mahmoud.
Hey, how are you?
Fine. And you?
Ready?
Inshallah.
Okay. I will share my screen and I will make a small test that you can control my screen. I will give you the remote control. What is your name here? Yeah, I found you. Okay. You are now? Yeah, click on my screen
Okay.
and then try to use the keyboard. The keyboard, right and left arrows better. The
I'm
keyboard.
trying.
Yeah,
It's
click
not
on the
working.
screen first. Click on the screen.
I clicked.
And try
Yes.
to right and left. Is it working? Because
Yes, I think it's
better
working.
than scrolling. Even in
Yeah.
the real exam, try to do your scrolling by the keyboard right and left. It is always better and smoother than the scrolling option. So I will start my timer now. This patient came in trauma.
Okay. I am presented with a brain CT without contrast in a patient presented with trauma. I can see there is a soft tissue hematoma around the right eye with also bone fracture. However, I would to review in the bone window. Also, there is air locules seen in the right frontal sinus. The right eye appears bulging. However, the globe appear intact. The lens appear intact. There is soft tissue swelling around the right eye. In the brain, yes, I can see some air locules in the brain. Also, there is a frontal bone fracture. There is a contusion. There is a contusion and brain hemorrhage in the frontal, in the right frontal lobe. A lot of scalp emphysema. There is a slight shift of the midline structure. Also, there is a shift of the ventricles to the left side. No subarachnoid hemorrhage.
Do you feel this is a contusion only?
No, it's brain hemorrhage.
What type of hemorrhage?
Intraparenchymal hemorrhage.
Only?
Also, I can observe that there is a extra or subdural hematoma.
Subdural only?
Subdural and extradural.
Okay, and what else? What could be emergency finding here?
The shift of the midline structures in emergency,
What
as
else?
it could represent herniation.
Herniation? Is there any herniation here?
I think there is subfalcine herniation.
Where it is? Can you show me?
Here.
Is there any other herniation?
I think I would review the other reconstructions to evaluate for
Other type? What are the other types of herniation?
subfalcine herniation.
Yes, what are the other types?
Sorry, I can't remember.
Okay, no problem. What you will do next?
Next, I will refer urgently to the neurosurgery team to do evacuation.
Okay, I have another exam for you. This is after evacuation. Can you scroll?
Okay. I can see there is a nasogastric tube. Also, there is an endotracheal tube. There is hematoma in the right maxillary sinus. Okay, there is a low signal, low density in both low density areas in the both frontal lobes, suggesting of ischemia.
Why?
Due to mass effect and herniation.
What happened?
Herniation caused mass effect in the anterior cerebral arteries bilaterally. So,
okay, what else you can see?
I can see there is air locules in the intracranial fossa.
Any other areas of hypodensity, as you mentioned?
Yes, I can see there is a hypotensity area in the right and left basal ganglia.
Anything else?
Also, there is a hypotensive area in the right parietal lobe.
So what is your conclusion here? What happened?
My conclusion there is a frontal lobe herniation causing ischemic changes in both frontal, mediastinal, and frontal and basal ganglia and parietal lobe.
Okay. In keeping with infarcts?
Ischemic with infarcts, yes.
Okay, thank you. This is another case. Do you know where is the abnormality?
I think it's in the mediastinum.
Mediastinum. Why?
Because I can't evaluate the aortic knuckle.
Hmm.
Okay.
So where it is?
It is a posterior mediastinal mass because there is a positive hilar overlay sign. I can see the arteries, the left pulmonary arteries.
Hmm. It cannot be anterior.
Also, it can be anterior, yes.
Hmm.
The heart border is not is silhouetting with this opacity.
So it is anterior or posterior?
As it is silhouetting with the right heart border, it is anterior. I can see faint shadow of the posterior of the aortic arch, of the aortic knuckle, and I cannot separate the opacity from the left heart border.
Anything
So
else you can see here?
yes, I can see there is an opacity here
Hmm.
in the left lower lung zone.
What you will do next, and what is your differential for now?
I will do CT with IV contrast to more evaluate this mass, as this is an anterior mediastinal mass. It could be, I will correlate with the history. It could be the differential diagnosis. It could be thymoma. However, this is appeared to be a young patient. Could be lymphoma. As it is not continuous with the neck, it is not likely to be a thyroid. It could be also a teratoma. I would check in the CT for
Right.
fat densities.
Okay, try to scroll. This is the CT with the same patient.
Okay. Okay, I can see an aortic aneurysm surrounded by mural hematoma. There is the aneurysm appear to be distal, yes, distal to the left subclavian artery, which is Stanford B. I can see any hematoma in the lung at this window. There is no, there is a small hematoma or increased densities, opacities in the left lung could represent hemorrhage. So this is an emergent finding. I would pick up the phone and call the vascular and interventional radiology team for these findings, as it is there is an active extravasation from this aortic aneurysm.
What else you should search for?
Okay, I would search for if this is there is okay. If there is a history of trauma or spontaneous rupture, I would check for if there is any flap or which I can't see here.
Anything else?
For me, it is an aortic aneurysm with a mural hematoma, intramural
What do you think
hematoma.
could be the treatment for this patient?
I think the treatment would be an TVAR, thoracic endovascular aortic repair.
Okay. This is another patient with pelvic pain.
Okay.
Do you know what is this sequence?
This is T2, fat sat, or stair. Okay, this is stair images, axial cuts of a female patient complaining of pelvic pain.
Yes.
Okay, I can see the ovaries appear normal. What fix my...
Sorry, you mentioned the female patient, or you mentioned the sex of the patient? I didn't hear you well.
Okay, he is a male patient. I thought you told me she's a female. Sorry.
I don't remember really. Okay.
Okay. No, this is a male patient. I can appreciate a striking abnormality that there is abnormal area, abnormal mixed signals in the right pelvic iliac bone, right iliac bone, extending to the surrounding soft tissue to the muscles. The bone appear distracted. Okay, and there is heterogeneous mass originating from the right ilium, from the right iliac bone. So we are dealing with a bone mass.
What do you think? What could
I
it
think,
be?
okay, I think this is an aggressive lesion. Differential diagnosis could include osteosarcoma, could also could be a soft tissue sarcoma invading the bone.
The most common bone lesion.
Most common aggressive bone lesion.
Yes.
Osteosarcoma.
The most common.
Metastasis.
Metastasis. Excellent.
Yes,
Do you
metastasis.
think this could be metastasis?
I will search for a source of metastasis in these images. In a male patient, I would search for the prostate, which I think it appears.
I don't believe prostate can send this kind of aggressive.
Okay.
What else?
Colonic CA.
Excellent.
Okay. And I cannot. There is a fat expansion, or the perifat, the perirectal fat area is appear enlarged.
Is there anything else? What is that?
Where here?
No, anteriorly?
I think this is stoma.
Stoma? Denoting what?
Denoting a previous surgery for colonic CA.
What you will do next?
Staging CT. Okay, I will check also previous images and correlate with the history.
Okay, thank you. Time is up. Thanks.
Thank you, Doctor.
Hello, Dr. Lais. How are you?
Hello, Dr. Muhammad.
I hope you are doing well.
Inshallah.
Okay, let's go.
Okay.
I will share my screen now, and then you can start the next 15 minutes. Okay. Okay, this baby is in ICU since 15 days.
Okay. This is a frontal chest and abdomen radiograph of neonatal baby. First of all, I can see there is an endotracheal tube that appears to be down in the trachea. I would recommend to slight withdraw. Also, I can see the nasogastric tube appear in good position. I can notice that there are linear opacities, linear lucencies in the right and left lung lobes. Also, I can see there is increased lucency in the upper lung, right upper lung lobe, and in the right costophrenic angle. However, I can't see the deep sulcus sign.
So what do you mean by deep sulcus? What do you mean?
Evidence of pneumothorax.
Okay.
Okay. Also, I can see bilateral symmetrical ground glass opacities. Also, there is
So
no.
what is going on here now?
My interpretation, I think there is these lucencies with the history of 10 days on ventilation. This can be goes with interstitial emphysema that might cause pneumothorax in the right side. In the abdomen, the bowel loops appear normal. I can't see evidence of pneumothorax, pneumoperitoneum.
Okay, so what do you think this condition causes, or why this happened, and what is your next step here?
Okay, I think this is a case of respiratory distress syndrome, and he was treated with intubation and surfactant. After intubation, due to high pressure of ventilation, that causes these these air streaks abnormalities. I would recommend to decrease the pressure of the ventilation and follow up the patient.
Okay, so there is no intervention in this case?
Okay, I would recommend also lateral decubitus to visualize if there is pneumothorax. And if I see pneumothorax, I would recommend a chest tube.
Okay. This is after insertion with chest tube. What do you think? Is it still there or gone?
No, it was gone.
Okay, so it's now relieved.
Yes.
Okay, thank you. I'm going to move to another case. Okay, this female patient, old lady, in fact, she presented with abdominal pain and vaginal bleed. So let me give you control to scroll the case. Okay, you can scroll now.
Okay.
You can use up and down arrows. Okay, use up and down arrows, better.
Okay. This is an abdominal CT with IV contrast. I will scroll, then take a general look, and then will give my comments. Okay, this is abdominal CT with IV contrast and with IV and oral contrast in an elderly female patient complaining of vaginal bleeding and abdominal pain. I can see that the uterus appear. I can note that the uterus is fluid filled with air locules and causing compression in the bladder. Also, I can note that there is loss of fat gland between the uterus and the bladder.
Okay.
Okay. Also, I can note that there is a mass in the left adnexia. Okay, there is a thick wall enhancement in this area.
So what do you think now is going on?
Here I think there is a cervical or uterine mass that invades the urinary bladder and causing some sort of fistula. So the uterus is filled with the same density as the urinary bladder. I'm thinking of fistula with the urinary bladder.
Okay, is this the only explanation of this?
It could be also could be necrosis.
Okay.
Okay, I would like to comment on
So
the lymph.
why there is an air there? You mentioned air foci.
Yes, there is air foci.
Yeah.
Mm.
What do you think? Why there is air here?
Could be also there is a fistula with the bowel loops.
Okay, so how to be sure about this?
I would review this study in other reconstructions. Also, I can do barium study.
Barium. Are going to use barium in this case.
Contrast.
What kind of
No.
contrast?
The contrast that are used in the CT.
Okay.
Okay, here I can appreciate that there is a connection here between the uterus and the surrounding tissue. I think it's the rectum. No, the rectum is in the posterior aspect.
Okay. So can you give me a final decision here? What is your next plan? What is the main differential in this case? You mentioned cervical carcinoma and I think endometrial. Are you still in this with this diagnosis, or you changed your mind?
I think if I am still with this diagnosis, endometrial CA with invasion to the surrounding
So
tissue.
what is this structure that you are mentioning? This is filled with fluid. What do you think? In sagittal, I think it's more clear now. Okay, so you are worried about fistula. You are worried about invasion. So what is your next step here?
I would convey my findings to the referring physician. I would suggest surgery is and exploration is the best next step.
Okay, great. So let's move to another case. This patient is unwell, totally unwell patient. So I gave you the CT scan to scroll. The patient presented with abdominal pain, and the patient is totally unwell.
Okay.
You can scroll up.
Yes. This is a chest, or this is an abdominal CT without contrast in a patient who presented generally unwell. Okay, I can see a huge ascites surrounding the liver and the spleen. I would scroll to the last cut and to take a general idea. Actually, I can't really appreciate. I think it is with contrast. Okay, so there is it has stopped scrolling. Hello?
I can see you are scrolling, Dr. Life.
Okay, do you hear me, sir?
You can scroll the case?
Yes, I
see.
can scroll. I can
Yeah.
scroll. Okay.
No, sorry. You are taking the control. I'm muted. So I'm sorry. So yeah, you are scrolling now. Yeah, go ahead.
And now it's stopped.
Yeah, you can scroll again. Yeah.
Okay. Okay. I can see there is a fluid collection here in the okay. Yes, I can see a fluid collection here in the supposed area of the pancreas. Uh,
So
yes, this area appears to be of a fluid density surrounding the pancreas with no air locules. Okay, there is surrounding fat stranding, surrounding free fluid, or there is free fluid in the whole abdomen. The gallbladder shows no stones. I can't appreciate dilated CBD. Okay, the vessels appear intact. No filling defects. No aneurysmal dilatation of the vessels, nearby vessels. In summary, there is a fluid density surrounding the pancreas. I'm thinking of necrotizing pancreatitis.
So what is your next step now?
I would like to correlate with amylase and lipase. Also, if this is an emergency case, I would pick up the phone and contact the surgical team for urgent treatment.
Any rule of intervention here in this case?
I think this is an urgent, not a pseudocyst. So, and there is no vascular abnormalities. So, the rule is for the surgeons.
The rule for what? So,
for the
what?
surgeons here.
Okay. Okay. Thank you very much for this. I think time is up.
Okay, thank you, Dr.
Yeah. Okay. Dr. Said, do you want to start your feedback or I'll start?
No, you can continue.
Okay. Okay. There is a lot of types of examiners in the exam setting. Dr. Lais, you are facing some examiners. They are going to hunt you in each word you are telling. Just asking with each word they are going to discuss with you, are pushing you towards some things. Some are giving you some help and some are going to be silent. So there is a lot of you must be familiar with such scenarios. Okay, you are expected in the exam scenario to take the case without any help. You need to do the case all, describe all the findings, tell the necessary knowledge that you know about the condition or the case. If you can show the examiner that you have some such knowledge, let me discuss the cases with you. In this case, you wait me until I asked you about the condition. You need to tell me that I am going to review previous imaging because I am suspecting this patient having or had a history of respiratory distress syndrome since birth, and maybe he ventilated for this reason. And with ventilation, we are expecting the patient to get such scenario. You are going to tell me what you know about pulmonary interstitial emphysema, okay? And that
I shouldn't wait you to ask me.
Yeah. Don't wait the examiners. So some examiners are going to ask you, but their pens are on the sheet of the marks. He didn't tell anything about the condition. So in the knowledge section, he is going to take 1, 0. Okay. So now it's very complex. They are going to divide all this and they must put a mark. So some examiners are exhausted in the whole day. They are examining a lot of candidates. So he's going to put the giving you some history, putting the film, and waiting you to make all the job. And this is expected from all colleagues. So and this is even the examiner is going to help you. This help will not be without any deduction of your marks. They are going to take from your marks. Okay, if someone is going to help you, as Dr. Saidi is going to tell what else, this is not good in the exam. You are going to lose marks because you make the Dr. Saidi make a lot of effort behind you. You got the idea? So it's very important. So this you make the diagnosis, you told something, some fine tuning about the condition. You need to tell me the next step without asking. You need to tell me that when you pick could be an emergency, we must urgently contact the team to decrease the ventilator parameters or decrease the pressure. We need to maybe insert a chest tube. We need to contact the team. We need to make a follow-up X-ray after this, inserting the tube to be sure that there is nothing. We need to review the previous imaging and make some comparison between and how progression how is the progression of the case. This is very important and critical. Okay, so this is very important in such cases. Okay, so this is the first. In this case, you did great. The second one with me, this cervical carcinoma. You need to be to tell also here to make some interpretation. This clinical reasoning here is very important. Don't put this is a case for differential. You need to see the sagittal, you need to see the coronal, you need to correlate with ultrasound, must be done before this case. So you need to ask about any transvaginal ultrasound. Ultrasound can help you. Is it vagina? Is there any imaging related to this condition? Any previous imaging before this this case? This is very important in this case. And explanation what is going on is very important, especially with the sagittal plane. When I present you sagittal plane, it's more obvious. What is this? It's an obstructed uterus. Okay, why? There is a mass obstructing at the cervical level or at the cervix. This is obstructing the uterus with retained fluid and air foci. This could be due to endometritis, due to infection, and this retained collection can be infected and having some gas, or can be due to fistula. Excellent. And this will be explained by the clinical data of the patient. If the patient is having fever or having or the patient is having, so this can be explained maybe by sagittal or by giving rectal contrast, okay, which is must be water soluble, I think, because if you are going to introduce something like what you said, it will be a problem, big problem
Yes.
in the exam scenario. Here, it's a retroverted uterus. That's why this is a posterior in location. So it's a retroverted, and it's obviously here. So this is explanation why this is anatomical variant. The uterus is retroverted, and there's obstruction by the mass causing a retain of the collection. So this is also very good. But you reached the diagnosis. This is a good one. I think you are not going to tell surgery. You can recommend in cervical carcinoma. We need to maybe have this rectal to be sure there is no fistula. Maybe do an MRI study for the patient to see to make some staging before telling. We need to check the bone, check the rest of the organs for any metastatic disease. You need to make some workup before going to surgery. You are going to discuss this in oncology or multidisciplinary team, but you must do the full work of in the radiology department. Maybe you are going to recommend biopsy for the case with gynecological team. So this will be the next step before surgery, I think, to make something. Okay, and necrotizing pancreatitis, I think you did great. Sorry, let me take from you the remote control so you can move. Okay, in this case, also you mentioned most of the things that I want to hear as a findings, but you need to do the full work of, as I told you, as a general comment, you need to make the full work about the case. You did a lot, a good job by telling there is no gallstones, there is no intrahepatic radical dilatation, but you need to tell me which part is necrotic and which part is not necrotic. What is the percentage of the necrotic pancreas? Is it all necrosis is of the whole organ, or still there is some area of not necrotic? And this is collection. What is the name of this collection? Okay, all of necrosis. So you are going to ask for intervention. Maybe there is some drainage of such intervention. I think can have some, because the patient is totally unwell and the patient may be having a very serious condition in such a scenario. Telling the complications and make a checklist for this is very good. Also, thank you for this, and I want to leave the mic to Dr. Saidi quickly because
Thank you, Dr.
we are in shortage of time. Thank you very much, Dr. Lais, for
Thank you.
Hello, Dr. Light. How are you?
Hello, Dr. Muhammad.
Nawar. Okay, I don't want you to feel upset or feel down. This is a training practice. The most important thing is to develop approach, to develop a scheme that you will go through it in each case. This is the most important thing. As you see, most of the cases, even all the cases, you will reach the diagnosis easily. It will not be difficult, but the problem in the exam that you should cover all the aspects, because each and several things they are testing you on, not only the diagnosis, not only the knowledge, not only this radiological stuff only. So you have to cover all the points, all the aspects for the case. As a general advice from my side, first try to take a general look in the images you have from the first cut to the last cut to see a general idea to know what is going on, where is the main abnormality. And then you should start by the lines and the tubes if they are existed, and you must start by the main finding. Go for the head, go for the main abnormality included in the images, describe it very well, its extensions, relations, how it looks like, and then ask yourself, what is the underlying cause? What is the expected complication? What could be emergency finding in this case? And you should answer these questions instantly by yourself without waiting for the examiner to ask you. Because there is a problem whenever the examiner started to ask you, So he will take from your marks, even if you answered correctly. As we see, you answered most of the questions correctly. So you know the information, you know the findings. Why didn't mention it in the beginning without prompted or without helping from the examiner? Let's see the first case. This was trauma. You started by the hematoma and this stuff and the bone fractures. But from my point of view, you must take a general look first and then start by the main abnormality, the main finding. The main abnormality here is the traumatic brain injuries. And you have to enumerate the injuries, not only mentioning that it is a contusion and run away. Because if you look for it, look to it, you will find a subdural component, extradural component, another subdural component. You may find some brain contusions, but the main abnormality here was the subdural and extradural hemorrhages. Okay, and you prompted for that. The other thing, you mentioned that there is midline shift, but you stopped there. You should continue to enumerate again the emergency findings, that there is a brain herniation. This is more important because brain herniation equals brain death. Because as you saw, we were late a little bit, or the time didn't save us. In this case, even after the surgery, the patient got infarctions because it is a very precious time. So the brain herniation is very critical thing to mention, even without anybody questioning you or asking you for it. You mentioned the subfalcine herniation, but you didn't mention the ankle herniation. You cannot see any basal cistern here. So there is also transtentorial ankle herniation. The subfalcine will obstruct or will compress the anterior cerebral arteries. The ankle herniation will compress the posterior cerebral arteries. As you mentioned, in the post-operative, also in the post-operative, you started by the maxillary sinus and this stuff. No, you should start again from the main abnormality, from the main finding, from the major problem. You should start from here. What happened to the subdural and extradural? There is craniotomy and drainage of the collection, but unfortunately, the patient developed infarct. He has bilateral ACAs, bilateral frontal lobes, and also this is the distribution of the PCA. So the PCA also was involved. So you should mention the arterial territories. Okay, this was for as a general idea for this case, but the approach is the most important thing. Because if you don't have a clear approach or a clear checklist for the cases, you will keep forgetting important stuff and you will keep losing marks, even if you get the correct diagnosis. For this case, you started very well that it is a mediastinal lesion. It is not lung because it is obtuse angle. It has obtuse angle with the lung. And then you must mention the specific location in the mediastinum, anterior, middle, or posterior, and you should clarify it. So you mentioned the positive higher limb overlay sign, and you mentioned the silhouetting of the partial silhouetting of the aortic knuckle, and there is some clear border of the left heart. So it is not exclusively anterior and not exclusively posterior. As we saw the CT, it has a component anterior and has another component posterior because it continues in the descending thoracic aorta and it is a posterior mediastinal structure. So this is the point. And then you mentioned the opacity. Good. Let's go for the CT. It was, yeah, I think this is the CT for it. Yes, this was a very good start because you started by the main abnormality again. You started by the aneurysm and the extensions where it was. I feel it also affected the ascending aorta. This is not the normal caliber for the ascending. So I feel that extends there also, not only started from the arch or distal to subclavian origin. So I feel it is Stanford A. The other thing you mentioned in the lung, the left lung, try to describe or to use the common words or the buzzwords that they are using. So here, opacity in the lung is better than hematoma. They don't use the description of hematoma a lot in the lung. They
Okay.
describe as opacity, ground glass opacity, or consolidation. And then in the interpretation, they could mention possibility of contusion or blood or something like that, but not specifically a hematoma word. And also, you didn't mention the pleura. Is there any pleural fluid or not? Because this is important to know. Another thing, you can feel there is some hyperdensity outside the wall. This also increase the possibility of rupture or leakage. Also, you didn't mention at all the end of the aneurysm, where it extends to. You should mention the beginning and the end. If you mention the end, you will mention as well the branches, the major branches. Are they patent or not? Are there is any narrowing or obstruction or thrombosis in one of them? And accordingly, the solid organs. Also, you didn't comment on the solid organs at all. Also, for the lung, you should ask for the lung window, even if he didn't give you the lung window.
Thank you,
The
Doc.
last case was this one, and you have been prompted a lot also in this case. If you have something like that large, extensive, extending to many surrounding structures, always ask yourself, where is the critical part or where is the emergency finding? One of the emergency finding here is extending to the spinal canal and the neuroforamen, because this needs urgent intervention. Okay, this is very painful and it will affect the nerve and it needs urgent intervention. So you have to ask yourself always, where is the important parts, the emergency findings, and go for it. And then the clinical knowledge part, that you should know that the most common bone mass is metastasis. So you should start from there and look for the primary or any signs of a previous primary like this one. When I asked you, you told me easily that could be a stoma and there could be a colonic cancer and the rest of the story. So you know the information, but you still lose some marks for that. Okay?
Okay.
Okay. Good luck.
Thank you, Dr. Ahmed.
Bye bye.
Bye bye.
So you will go for a small break and then we will come back and we will
Yeah,
ask
if we can
another
take
panel.
just
Okay.
another 5 minutes only, 5 minutes of break for Maghrib prayers, and then we will continue with Dr. Rizk and Dr. Saidi. Okay?
And we will need another candidate for the
Yeah,
next, for the other
yeah,
session.
we,
Okay.
we will need another candidate. We'll do a live draw once we get
Okay.
back from the break. Okay?
Okay. Waiting for you.
Like we did before. I'll leave a couple of minutes for people to write down their names in the comments. Let me share my screen and then we can do the ballot for the second part. Yeah, I think I got all of the names, maybe Dr. Ala as well. Okay. And we have Ihab. He is going to be our hot seat for the second part of tonight. I'll leave you with one of the instructors to start the exam.
Dr. Rez joined us.
I believe he did, yeah.
السلام
I think
عليكم.
He's very
I'm
ready.
ready. السلام عليكم. كيف الحال? How are you? I hope you are doing well. Are you ready for the exam, Dr. Ihab?
السلام عليكم.
عليكم السلام. So you are ready.
الحمد لله ready يا
So I
دكتور رزق.
give you scroll. So I will give you a scroll right now, so you can be able to scroll for, or I can scroll for you if you like. So this patient have a headache and bring you this MRI images, so you can scroll them and tell them what the reason for headache in this patient.
axial flare for whole brain. There is no extra or intracerebral areas of blood degradation by product, no midline shift, normal ventricular system. Normal posterior fossa. Can I see the other sequences, Dr. Rizk? There is a small right-left mastoiditis.
So I have T2. I will show to you. Maybe it can be.
No intra or extra-axial areas of blood degradation by product. No midline shifts. Normal posterior fossa.
So you cannot keep much silence. So what do you see? And give me.
There is no significant
think?
abnormality. Normal ventricular system. No cortical.
So what is the reason? What do you think? What could be the reason for headache in this patient?
There is a mild left mastoiditis.
So mastoiditis is the reason of headache in this patient. What you recommend to do next?
I wanted to do MRI for posterior fossa and the nasopharyngeal area.
Okay, do you like to add any differential in your mind? Do you have any?
I wanted to see a coronal sagittal.
Okay. There is a coronal T2 here. Yes, you can check.
Control معايا. I have control.
Yes. You have the control, yes.
There is left mastoiditis displaying a high signal in coronal T2 image.
Okay.
There is no parapharyngeal masses. Hypertrophy of the tonsils. I want to see the dural sinuses if there is MRV or MRA sequence.
So what do you like to check the MRA or MRV in this patient? What do you
See the
suspect?
to see the patency of the dural sinuses.
What do you suspect in this patient?
Suspect some sort of thrombosis, dural venous sinus thrombosis.
At which part? At which part?
At the transverse sinuses, the lateral end of the transverse sinuses and sigmoid.
In the right or in the left?
On the left. يعني there is sinus.
Are you sure? Are you sure in the left or in the right?
There is a signal, there is a high signal.
Okay. Is it in the right or the left? What do you think?
It is on the right.
In the right side, okay. So what do you like to do for this patient?
There is
Okay.
I have no control.
Okay, I will take the control, yes. So my question for you, what you like to do for this patient as next? What you like to do?
I wanted to do a diffusion weighted image and ADC map to see any venous infarcts, acute type or hyperacute type.
Okay. Let's shift to this 4 years patient who have pain and moving his hand so much for his parents. The parents claim that he have much pain, and they do this X-ray. What is your comment about this X-ray?
There is a bilateral extensive periosteal reaction surrounding the shaft, most of the shaft of the radius bone. There is no displacement. There is no non-displaced fracture, no fracture with displacement, no dislocation. Periosteal or diffuse periosteal reaction along the radial bone shaft, suggestive of non-accidental injury. Second, maybe infantile cortical hyperestosis in other differential diagnosis. But on top of differential diagnosis is non-accidental injury. There is no elbow dislocation or wrist dislocation, no soft tissue swelling. I will convey finding to the referral clinician and clinical history for any non-accidental injury and any type of child abuse and big phone to a child protective surface and do other X-ray views.
So the pediatric consultant checked this patient and he confirmed for you that there is no child abuse and there is no non-accidental injury. What you are going to do next?
X-ray other views and X-ray for skeletal survey for the other views. Maybe
they ask you to do this ultrasound for this patient. What do you think? Is acceptable or not?
There is cortical break. There is fracture here. I think this is a fracture. This is for the forearm. Some sort of edema, soft tissue edema, and I think this is cortical break.
Ignore this because maybe this is just the connection between the epiphyses and the metaphyses, if you agree with me.
Okay.
Okay. So what do you think about the other findings here?
Maybe this subperiosteal elevation and the surrounding soft tissue edema.
Okay, yes. So what do you think about this collection and this edema? What it could be?
Maybe hematoma, some sort of hematoma.
But as I told you, the pediatric consultant confirmed that there is no trauma.
No, there is no what?
There is no trauma. There is no trauma.
No trauma.
Yes. And there is no non-accidental injury. Do you have any recommendation what could be and what we'll do next for this clinical situation right now?
See previous imaging study and arrange for other X-ray for other bone and arrange.
Do you think that the X-ray for this patient will add any value? I mean, right now in the same sitting, or would like to do MRI? What do you think? Would you like to do MRI?
Okay, for
it can be of added value for this patient, right? Okay, let's see what MRI. You can have scroll and you can scroll, like.
There is a massive edema of the radial bone associated with the surrounding soft tissue edematous changes. Suggestive
I would
of
like to show you
inflammatory process.
Yes.
Suggestive of inflammatory process affecting the radial bone, the whole shaft of the radial bone, with subperiosteal reaction, likely inflammatory changes like osteomyelitis. I will convey finding to the referral clinician and arrange for measurement laboratory study as inflammatory markers. and arrange with previous X-ray studies and studies. I think this is a diffuse inflammatory changes of the radial bone like osteomyelitis. Beginning with antibiotic treatment.
So the final decision in this case will be osteomyelitis. What you are going to do next?
Refer verifying to the referral clinician and arrange urgent case with the beginning of antibiotic treatment and laboratory studies for inflammatory markers. And
okay,
I think
let's shift to this patient who have chest pain and bony pains. They ask you to comment about this CT. What do you think?
there is multiple. Okay. This is coronal CT scan bone window for the chest and abdomen and the pelvis revealed multiple sclerotic deposits affecting the whole dorsal and lumbar as vertebrae as well as the pelvic bones, suggestive of metastatic process, sclerotic metastatic process. I wanted to do first arrange for the clinical finding if there is any primary tumor, non-primary tumor, and do bone scan to assess the rest of the other bones. Number two, CT staging. And
so this patient, as you mentioned, he need the bone scan. So he did this bone scan. What do you think?
there is super scan. There is no opacification of both kidneys. There is multiple widespread deposits affecting most of the axial skeleton, showing diffuse, showing hot uptake. Marked hot uptake are seen at the left pelvic bone. There is diffuse metastatic process, and we arrange for metastatic workup and arrange for research for primary tumor, primary malignancy. Also,
so
there is uptake at
which type of malignancy do you think that this patient have?
If the patient is male, arrange prostatic cancer on top of the primary malignancy.
Do you think that this patient is a female or male? What do you think?
No, I think it is a male patient.
Yes. So which type of cancer is?
Prostatic carcinoma, bronchogenic carcinoma, colonic carcinoma, on top of the primary malignancy with metastatic with sclerotic deposit.
Okay, so what you are going to do next for this patient?
We can do a CT staging, CT body, or more better PET CT scan to search for the primary malignancy if it is unknown.
Thank you, Dr. Ihab. Now I will shift and will be the feedback after Dr. Mahmoud feedback. Thank you so much. Thank you.
Assalamu alaikum. How are you, Dr. Ihab?
عليكم السلام ورحمة الله دكتور محمود.
Nice to have you again.
الحمد لله.
Okay, let's make a small test. I will give you the remote control. Yes. Click on the screen. And yeah, perfect. Okay, this patient has cough.
I will scroll from the start till the end image and I will say my opinion.
Okay.
There is axial CT scan of the chest and abdomen and the pelvis, portovenous phase. I can appreciate This is a female patient with
Female.
left breast hypoattenuating two soft tissue lesions with irregular outlines associated with mild skin thickening, underlying skin thickening. I want to arrange to highlight on this breast mass and do mammography and ultrasound and compare with the previous imaging study, and if the patient has any history of primary malignancy and any malignancy of the breast.
How is the
Regarding
nipple?
now, there is mild retraction to the nipple, thickening of
Okay.
the overlying skin with mild retraction to the nipple, and the mass shows microlupulation, and the surrounding strange reticulation with the architectural distortion. I wanted to see the mammogram and the ultrasound because breast cancer or malignancy is highly suggestive regarding the chest of regarding the CT of the chest and abdomen. Regarding the mediastinal window, there is no few axillary lymph node I can see on the left side. No mediastinal or hilar lymph node enlargement. The cardiac side within normal. Regarding the abdomen, there is hypodense focal lesion, marginally enhancing or peripherally enhancing hypodense focal lesion in the lateral segment of the left hepatic lobe, about 2 centimeters in diameter. There is a small left kidney simple cortical cyst about 1.5 centimeters, no retroperitoneal lymphadenopathy, spleen and pancreas and both kidneys within average, no abnormality, no abdominal lymphadenopathy. Regarding the pelvic structure, uterus and urinary bladder are good. I want to assess the lung window and the bone window to assess any
lung window.
Yes, lung window well aerated both lungs with no there is few nodules, tiny pulmonary nodules at the right side, right lower lung lobe.
Okay, this is the bone window.
The bone window, I want to arrange bone window for any metastatic deposits. Regarding the ribs and the dorsal vertebrae, there is osteolytic lesion. We can assess osteolytic lesion in one of the dorsal vertebrae. Multiple sclerotic and osteolytic lesion in the dorsal vertebrae. Likely,
okay. So what is your conclusion? What is your conclusion?
left breast aggressive neoplastic mass lesion, likely breast carcinoma
With
liver and bone metastasis.
Okay, this is the mammogram you asked for the same patient.
There is soft tissue mass lesion with lupulation, microlupulation, and surrounding strand reticulation with architectural distortion associated with soft tissue thickening and mild nipple retraction. By RADS 4 to 5, I think by RADS 4 or 4 to 5.
Are you satisfied with this view? What is this view?
I wanted to do magnification to assess any microcalcification.
Yes, what is this view?
Sorry, what?
What is the view?
This is هو mediolateral oblique, left mediolateral oblique.
Are you satisfied with it?
There is no pectoralis. لا, I am not satisfied.
Why?
No inferior mammary fold, no pectoralis major muscle, pectoralis shadow.
So what is your recommendation here?
I do other views, magnification view, axillary view, and ultrasound and biopsy.
Nice. This is another patient complaining of headache.
Yes. Multiple CT scan of the upper neck and brain shows soft tissue, lobulated soft tissue mass lesion at the right parapharyngeal space, indenting the right lateral wall of the naso and oropharynx. Measures about 3 by 4 centimeter. It shows non-homogeneous enhancement. This is with contrast.
Enhancement?
Sorry, this is without contrast. This is without contrast.
Hmm.
This is without contrast.
Hmm.
This is right parapharyngeal, soft lobulated, soft tissue mass lesion, indenting the right lateral wall of the oropharynx, encroaching laterally on the carotid vessel without invasion. I want to see the bone window to assess the underlying changes of the underlying bone. And I want to do CT with contrast or MRI for better characterization, soft tissue characterization, nasopharyngeal carcinoma on top of my differential diagnosis. There is multiple bilateral upper and lower cervical lymph node, pathologically enlarged lymph nodes, more on the right side.
What else in your mind?
Sorry?
What else in your mind?
Lymphoma and lymphoma. يعني other differential diagnosis. نعم.
What
Sorry?
else? What else?
Lymphoma, nasopharyngeal carcinoma, metastatic process, any other disease of like leukemia,
Anything else?
on basis of this study, يعني metastatic process. There is intraparotid lymph node also enlargement, lymphoma, leukemia.
Do you recommend anything else other than the contrast and MRI?
يعني CT, PET CT for see other organs or any hot uptake in abdominal, liver, and spleen. And
Okay. Thank you. This is another case. The patient has cough.
Chest radiograph, frontal view for skeletal mature patient. There is reduced volume of the right hemisthorax, showing lobulated soft tissue circumferential opacity surrounding the right lung with elevated of the right diaphragmatic copula, alveolar densities, and opacity seen affecting the right lung. There is no pneumothorax. I think small pleural effusion on the right side. The heart, the cardiac size within normal, no pneumothorax, no destructive bony lesion, no pneumomediastinum. The circumferential surrounding lobulated and nodular densities surrounding the right lung may be suggestive of mesothelioma. There is a mild shift, tracheal shift to the right side. I will convey this finding to the referral clinician, and I would like to take further this case to do CT scan, chest with contrast, to assess the right hemothorax pathology.
Any other possibilities other than mesothelioma?
Metastatic process, metastatic pleural process. There is metastatic process.
You can scroll.
Okay. There is CT chest with contrast. There is reduced volume of the right hemothorax. There is mild pleural thickening.
Do you still feel it is mesothelioma?
No, it is not. No. يعني there is reduced volume of the right hemothorax.
Okay.
I want to see and there is a mild mediastinal shift to the right side. I want to see lung window. Can I assess the lung window? There is interstitial and reticular soft tissue densities affecting the left, affecting the right and to less extent left lung, more predominantly affecting the upper and middle lung loops, relatively sparing lung bases. Suggestive of interstitial pulmonary and is a zonal affection more at the upper and middle lung loops, sparing the lower loops.
So what is your final decision? What final conclusion?
Interstitial lung disease like unusual pneumonia or non-specific interstitial pneumonia.
Anything else?
يعني ممكن برضو massive.
What is more common?
Sorry?
What is more common pathology affecting the lung?
يعني may TB, tuberculosis infection, TB.
What you will do next?
Sputum analysis and culture and sensitivity. And previous imaging study of there is previous imaging study for comparison. There is intrabronchial lesion here. I think this is mucus.
Okay, time is up. Thank you. Thank you. I will give you the feedback now. Let's go first let's take it by order. We started by this case. Okay, you did it very well. You started by a general look to see where is the main findings, the main abnormality, and you mentioned the exact phase of the scan. This was a very good start. Then you started by the main abnormality, but please, my advice is give a complete description with all the points. With you have to have a checklist. It is a must. So whenever I saw a breast mass, I should comment on one, two, three, four, five in order. And then after I finish them, I will start getting another point or another organ. So for the breast mass, you have to mention the mass itself, where it is, how it looks like. The size, you don't have to give a precise measurement because we don't have the measurements. So you can mention small or large like that. And then the related things like the skin and the nipple, because every point the examiner will prompt you or will help you in it, he will deduct marks instead of. So you mentioned the mass, you mentioned the skin, you mentioned the nipple. You must mention the axilla at once, not at the far end. You must comment on the other side, the right breast. I didn't hear you commenting on the right breast. Okay, then you move to the metastasis. Very good. You have three main metastasis sites: the lung, the bone, the liver. So the lung, you review it in the lung window, excellent. The bone, review it in the bone window, excellent. And the liver, you mentioned the possibility of the metastasis in the left lobe. Then at the far end of your comment, you can mention that there is a renal cyst, there is anything unrelated to the main abnormality. Okay, and then when we move to the mammogram, please start by commenting on the view, like what you did in the CT. You mentioned that this is a CT in a portovenous phase. I will take a general look. You should have the same start. This is a left MLO view, and you should comment on the view itself. It is missing the pectoralis muscle, missing the inframammary fold. You already know the information, but you didn't get the mark for it. You lost the mark and you know the information. So what is the benefit? Always remember that you are in an exam. The main goal in the exam that you get the marks. So you will pass the exam. All of us has the information. You are has experience, has information, but you must mention these points in the exam to get the marks. Okay, and then you continue it very well. I agree with everything you said. Then we moved to the this case. Really, this case was a fun case. It was a little bit difficult. The brain itself, there is nothing important. There is nothing that catch our eyes. You didn't comment on the brain at all. The ventricles, the brain tissue, there is no loss of gray white matter differentiation. You didn't mention anything. Even if it is normal, you must comment on the brain. Then you started by the mass. This is good. But you started that it is in a parapharyngeal space, okay, and it compress or indent the nasopharynx and the oropharynx. But you mentioned that it is heterogeneously enhancement and it is non-contrast study, so take care of these silly mistakes. Also, if you mentioned a mass, you must comment on the extensions. Is it you asked for a bone window, yes, but also you can find if there is any extensions to the nerve fibers, if it is continuous with any of the nerve fibers or the neural foramina, okay? And the lymph nodes. You mentioned the lymph nodes at the far end of your comment, of your description. This is not a good point also. You asked for the bone window, okay? And you mentioned that it didn't involve or invade the vessels. It is a good idea, but you have to wait for the contrast study to make sure that there is no involvement. Also, I can feel there is a lot of subcutaneous nodules, skin and subcutaneous nodules, especially in the posterior neck and the upper chest. Let's go to this window better. So, in my opinion, we should also add neurofibromas to the differential diagnosis. I know you will not get the correct diagnosis in such cases. You have to put a differential. You put a nasopharyngeal carcinoma with multiple metastases, and I don't feel this could be a good differential because you can see the lymph nodes is massive. It is innumerable. See, it is numerous in both sides. If it is nasopharyngeal carcinoma, it should first metastasize to the same side lymphadenopathy. You can see the lymph nodes even in the parotids, in the submental, in the sublingual, in the posterior aspect, in the upper chest, in the supraclavicular. So it is massive masses. It is not a metastatic lymph nodes from nasopharyngeal cancer. So I don't agree to put this in the, at least not put it as a main diagnosis or in the first differential. Lymphoma, I buy that. I agree. You can put lymphoma, but please don't forget the neurofibromas. Because neurofibromas are exactly like that. I know this is difficult because the neural foramina are mostly not widened or there is no intraspinal masses that to give the dumbbell shape of the neurofibroma, the classic dumbbell shape, but there is some skin and subcutaneous nodules and the extensive involvement in even in the axilla, see? So this extensive involvement, I think we should put neurofibroma in the differential diagnosis. The last one is for this. You mentioned the chest X-ray, good, that the main abnormality is like that, affecting the lung, the right hemothorax is collapsed, but you didn't mention the mediastinal shift. Only you mentioned it at the end, at the far end. You kept mentioning the no pneumothorax, no pneumomediastinum. I felt it is a little bit not related to the pathology here. But you didn't mention at all anything in the left lung, in the other side. And this is a very important part to comment on. See, there is left apical thickening, and always the apical thickening and the fibrotic appearance of the lung. I think mostly it should be related to a TB. So again, like the first session when I asked your colleague about what is the most common bone tumor or bone mass, he mentioned that it is metastasis. Again, here, the most common cause of bilateral apical lung fibrosis and fibrotic changes in the hemithorax is a TB. You mentioned the possibility of mesothelioma in the X-ray, and okay, no problem for that, but on the CT, it is very obvious that there is no pleural thickening at all. Oh, sorry, this is the CT. And there is no pleural thickening at all, so it is not mesothelioma. There is pericardial effusion as well. You commented here on the left lung, and this is a good idea, but you didn't mention at all anything about the lymph nodes or the bone. The bronchus, you mentioned it at the far end also, and it is only secretions. I don't feel there is a mass. It is only secretions in the bronchus, and what happened in the right lung, it is a fibrotic changes from long-standing TB. And always in the TB, make sure that it is not active TB because it will require isolation for the patient. So you must also mention that it is not active, there is no tree-embodied nodules or miliary nodules, and you have to check the sputum for activity, because if it is active, you must mention that the patient should go for isolation. Okay, thank you. And Dr. Rizk will be with you now for his feedback. Thanks a lot
هو
for
بعد
everybody.
اذنك يا دكتور محمود، هو
Yes,
بس حاله النيوروفايبروماتوزيس،
yes,
يعني هو اللي احنا شايفينه كله الماسيف ليمف نود والرايت بارافارنجيال ماس،
we
ما
are
فيش
massive
نوديول.
neurofibromas.
يعني اللي احنا يعني ما فيش ماسيف سكين نوديولز، ما فيش اي
Yes,
نيو.
but the extensive involvement on both sides of the neck, the upper chest, the axilla, the lower neck, all of this involvement should goes first to neurofibromas. And I agree that the possibility of lymphoma also we can add it as a possibility, but we cannot add the nasopharyngeal carcinoma as a possibility.
Okay.
Okay, thank you.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
دكتور إيهاب ما شاء الله عليك. You did well. لكن take care. You have to be as fast as you can when you talk about major. Here there is sinus thrombosis, as you see.
We can't hear you, Dr. Rez. We can't hear.
As you go to work, you will find
Dr.
of
Rez,
the right.
sorry,
Yes.
sorry. Can you repeat what you said because we lost your voice? Can you hear me?
الصوت رجع تاني ولا في؟
Yes, it was interrupted.
Okay, ماشي. Sorry. We talk about one of the major abnormality that you can face during the VIVA, the case of sinus thrombosis. And the sinus thrombosis, when you check for mastoiditis, you had to clearly focus in the sinuses and check the patency of the sinuses. One of the most complications that you can face in any case of sinus, any case of mastoiditis, that you can get a complication of sinus thrombosis, as in this case. And when you check, you'll find that there is bilateral mastoiditis, but there is in the right side clearly obliteration of the signal of the sinus, of the right sigmoid and transverse sinus. And this loss of flow void signal, if you go up a bit, you'll find in the upper, yes. Okay, you can check here or here, whatever you would like, but you'll find that there is a clear evidence of here, yes, exactly here. You will find that there is in the right side sinus obliterated of the sinus signal, and this is, and you after that you have to recommend in the same sitting that you have to do MRV if the patient there, so you have to do this. And yes, it was sinus thrombosis. You have to be, when you talk about major abnormality, you have to be quick to get the major abnormality. This is one of the most common exam cases, and even in the practice you will find much cases like this. So any case of sinusitis, of mastoiditis, you have to check clearly for the sinuses. This is one of the important tips to have to check. If we shift to the second case, the second case, yes. Yes, yes, I like your starting that you try to exclude the trauma issues, especially if this is emergency like non-accidental or critical like non-accidental injury, something important. But you have here to check also for the inflammatory reason like osteomyelitis, and here there is a periosteal reaction and subperiosteal elevation, as you mentioned that. And yes, there is after that all of this pathological fracture associated, yes. And one of the most common reason for this appearance is osteomyelitis. Sometimes it can be add as a differential some neoplastic processes, which can also cause like subperiosteal elevation or periosteal reaction like that. But you have to put in the differential osteomyelitis, check for inflammatory markers, and they recommend MRI. This patient did MRI, and you saw the signal in MRI, and there is a collection by ultrasound. There is a considerable collection that recommend that this patient have osteomyelitis, confirmed after that is osteomyelitis complication. There is two things in MSK, emergency, septic arthritis and osteomyelitis. You have to be careful of when you check them. Inflammatory processes need to be careful when you check for MSK. I like your answer, but you have to be careful about osteomyelitis. This is one of the most common causes and most common cases as well. Okay, let's shift to the last case, which is
معلش
I like.
ممكن يا دكتور ممكن يا
Okay.
دكتور رزق صورة السونار بس نشوفها نشوف الكونفكشن
راحت مني
خلاص ماشي
there is collection. This was collection, and there is again subperiosteal elevation, but on the ultrasound, yes, I cannot get it right now. The last case was the super scan. I like your answer because you go first to the kidney to check the tracer uptake in the kidney, and as you see, bravo, there is no tracer uptake in the kidney, and also in the soft tissue there is almost very little tracer uptake in the. This is for us is like a super scan. You have to check either metabolic or metastatic, and you can see that all of the metastatic process in the axial skeleton, even some of them in the reach to the brain, and there is brain metastasis as well. So in that case, this is typical case of osteoblastic metastasis in this patient who is a male. So we have to consider that this is a prostatic metastatic process. Thank you so much, Dr. Rehab. You did very well, but take care of the major abnormality, especially emergence. You have to be clear and fast and quick to pick up the abnormality and tell the examiner, especially if there is any infarction or any like this sign of thrombosis. You have to be careful. Thank you so much, and thank you for the event. Thank you so much.
شكرا يا دكتور رزق شكرا شكرا
Thank you all, our doctors, for your time and effort, and thank you for your tips and tricks. Hopefully, it will be useful for all our audience, those who have participated as a hot seater, or those who have enjoyed observing the interesting cases. We remind all of you that we are going to start our private VIVA course. It will run from the 12th to the 26th of September. There's two versions of it: the mini VIVA, which is 3 exams, and the full private VIVA course, which is 5 exams. These exams, you will have a full exam simulation, a full mock of the VIVA part, including 4 examiners, and getting full feedback, both written and oral, in order for you to practice this kind of a stressful situation, and hopefully it will amount to you passing in the first try, or this try at least, if you have tried before. If you'd like any more information about this, please contact us. You can reach us on our website, radmiradiology.com. You have all our contact info there. If you would like to be invited to more of our free activities, please just write your email in the comments section, and we'll make sure to engage you in our newsletter and all our future activities. Thank you all for attending this free session, and we hope to see you again, hopefully. Thank you.
محمود دكتور
ويتش محمود
السعيدي اهلا وسهلا
دكتور محمد.
ازيك يا دكتور محمود؟
الحمد لله.
اللي موجود بقى في النك ده كلها ليمف نود ولا نيورو فايبرومز؟
نيورو فايبرومز.
طب ما هم شبه الليمف نودز.
لا it is more extensive and innumerable.
We'll stop the recording now and leave old friends to keep talking to each other. Okay.
Okay.
هي extensive قوي على ان هي تبقى lymph nodes metastasis involving يعني كل الاكزيلا، كل النك، كل الليفلز بتاعت النك on both sides، والسبمن الباروتيد والسبمنتال والسبمنديبولر very extensive. يعني احنا طبعا مش بنختار الحالات، يعني المريض مش بيختار الفايندنج اللي بتبقى عنده. بس هو ايديالي اللي في الكتب ان انت بتلاقي ساعات بعضهم عامل دمبل شيبد على النيورال فورامينا، ولكن يعني الحالة دي ما كانتش موجودة فيها.
يعني دي نيورو فايبرومس.
دي طلعت في الاخر نيورو فايبرومس، خصوصا ان في حاجات سبكوتينيوس، يعني سبكوتينيوس يعني زيها زي النيورو فايبرومس برضه ممكن تبقى.
والماس نفسها اللي في نيزوفاريكس نيورو فايبرومس.
دي كلها نيورو فايبرومس،
حتى
لان
الكبيره
لان
الماس
انت اناتوميكالي اناتوميكالي
المين ماس نفسها.
المين ماس ديت اناتوميكالي واخده جزء من النيزوفارنكس على الاوروفارنكس ونازله لتحت، يعني اناتوميكالي مش ماس بتاعت نيزوفارنجيال كانسر، فاهم؟ لان
ما هياش
النيزوفارنجيال كانسر لو
هتبقى اجريسيف، هتاكل البون الاول حاجات تطلع عليها.
بالظبط، هي دي حنينه قوي، يعني هي واخده كذا ليفل وحنينه قوي ومش انفيدنج حتى الميوكوزا. انت يعني لو تفتكر الصور اللي بشوفها في الفيديو، الصور الميوكوزا انتكت،
مم.
يعني الميوكوزا كانت انتكت، فلو هي مس بالشكل الغريب ده يعني هتبقى اجريسيف بقى وهتطلع فوق حتى في النيزل كافيتي وتبقى اكستنسيف شويه عن كده.
نعم.
هي الفكره
ماشي
كلها
اتضح.
ان انت ازاي تخرج بالحاله، يعني ازاي تحط ديفرنشال ملائم للفايندنج، ما تلزقهاش في اي حاجه تيجي على بالك وخلاص. يعني دي باي حال من الاحوال مستحيل تبقى نيزوفارنجيال كارسينوم. اه انا اقبل منك ان انت تقول لي ليمفوما، ولكن برضو ما يعني لازم تحط في بالك البوسيبيليتي بتاعت النيوروفايبرومس.
طب الليمفوما كانت هتفرق ايه عن كده؟